Three.
I was just scratching.
So root canals, I mean, what are the reasons we end up having to have root canals? The nerve dies, not the root. So it's not just because, you know, we don't brush our teeth or we're just have bad hygiene. I mean, there's multiple reasons as we've kind of touched on as we've gone through the course, why a nerve dies. It's not just because we get big cavities and we need a root canal. There could be trauma to a tooth that causes a nerve to die. You could have a simple filling done on a tooth, and for whatever reason the nerve doesn't like that filling, and the tooth becomes sensitive and just goes downhill and it dies. And so in order to save a tooth, your only alternative is to do a root canal. It's an alternative to taking the tooth out. So you're doing it to hold on to it because your other option is to take it out and do an implant or replace a bridge or something like that. So I've got 4 root canals on my lower front teeth from trauma when I was in a swimming pool growing up that I didn't know about till many, many years later. Actually, I was a freshman in dental school when a classmate up above, you know, took x-rays on me, and we saw that my 4 front teeth were dead. So he ended up doing 4 root canals when I was in dental school. Knock on wood, they're still good. But just because you do have a root canal doesn't mean that it will succeed. There's always a possibility that a root canal can fail, and that's usually about a 5% failure rate for whatever reason. You know, there could be an accent, and as we'll see, we're kind of navigating through a little canal in the middle of the tooth, kind of blind. You know, we're just going through a little hole and feeling and seeing or kind of feeling our file bend through the inside of the canal and irrigating it and disinfecting the inside of the tooth, and then we plug it up. But I mean, we don't physically see what's going on, at least not yet. Eventually, I'm pretty sure the files will have little cameras and we'll be able to see where they're going. You know, there's so much technology now. But the endodontists, they do these root canals with microscopes. I mean, they just like I wear loops. They've got a microscope that swings off the side of the wall, and they're looking through this microscope and they see the tooth this big, you know, so they can see a lot more. And you know, I send them all those cases that I don't want to do because they do a much better job and a faster job. So again, it's not just because we get big cavities. And the specialist is called what? The endodontist. And I think one of you guys is going to go shadow or do shadowing there at Dr. Pena would read it. Have one of you guys over. So again, it's a little bit different, you know, than here. That's all they do. They do, and we'll talk about the surgeries that they do. And Dr. Pena now has expanded his practice and he places implants now, which they can do as well. So it's not just root canals that they do surgeries to try to save a tooth of a root canal that's failing. We'll talk about that. Anyway, endodontics is more commonly referred as root canal therapy, or RCT, root canal therapy. Is the dental specialty which focuses on the diagnosis and the treatment of the tooth pulp and the periapical, the tissues that are around the apex. So what are the needs? And we were just talking about that. Why do we need a root canal? When is it recommended? Okay. Usually, what? You get a patient that's in here and he's what? Or there, or she's pain. Usually that's what gets a patient in. You may have a patient that's got a huge hole in the tooth, but the tooth doesn't bother them. The tooth needs a root canal, but the body has dealt with it, and the patient comes in and I don't need a root canal, it doesn't hurt. You need a root canal. So, but the primary reason is pain. Good. No, that'll come up. Anyway, Lural's inflammation means there's some swelling underneath the tooth. Okay. the swelling, pressure underneath the tooth, or inflammation is what's causing the pain. And what's causing the inflammation is usually bacteria from the dying nerve tissue. Okay, so you've got inflammation, a dead nerve, necrotic nerve. Necrosis means dying or dead. So a dying nerve is causing bacteria to grow inside the tooth, go out the end of the root, which causes the inflammation, which causes the pain. Before we do a root canal, we have to decide whether the tooth is restorable. Because if I get a tooth that it's bombed out, you know, it's got a huge cavity, I don't have enough remaining tooth structure to build back on, then a root canal isn't indicated. You know, that tooth needs to be taken out. Okay, so it's indicated if it has gross inflammation, if the nerve is necrotic, and if I can save the tooth, if I can restore it. If not, the tooth needs to come out. It's indicated if there's a cavity that either mechanically, by me digging, or trauma, we see the pulp. That patient, I think we've seen that picture. Patient falls, breaks his front tooth, and it breaks, and you're broken into the pulp. Okay, so once the pulp is exposed, either by us digging, removing decay, or patient breaks their teeth, if the pulp is exposed, you get bacteria in there. The only way you can hold on to it is to do a root canal. If it's a minute exposure or a tiny exposure, sometimes we can do some other things that we'll talk about a little bit later on. Okay, so these four things are usually what indicate when a root canal is recommended. When do we don't want to do it? When is it not recommended? If there's not enough tooth, again, there's too much tooth loss, either the trauma or gross decay. But again, it's not an indication. I could do a root canal, but if I can't restore it, what good is the root canal? Again, due to decay, so either trauma or decay, we don't have enough tooth to save. Okay, if the tooth is positioned in a, you have a tooth, a molar in the back that's kind of sideways, and it's really not a functional tooth. You've got your lower molar here and your upper molar is going out this way. Are you going to spend over $2,000 on a tooth that's not functional? Again, that may be a decision for them. Maybe the patient wants a root canal, even though it doesn't function. He wants a root canal build up in a crown and spend $3,000 on a tooth that really has no function. But is it indicated? No, not really. If it has a lot of gum disease, if the tooth is kind of flopping in the wind, is it indicated for me to do a root canal? Probably not, because the tooth is going to be lost. One, the insurance is not going to pay. And two, again, is the patient willing to invest money to saving a tooth that it's got a poor prognosis? Okay, so we were, you guys, when I asked what are the reasons that usually a root canal is needed, and the primary one is pain. That's normally what will get a patient in. Again, they could have a big cavity, but the tooth isn't bothering them, and a lot of these emergency patients, they'll call. The pager will go off and we'll call, 10, 12 o'clock at night. Dr. Rosente or whoever's on call, Dr. Cervantes, this tooth has been bothering me, or I've felt the hole in there for months. It's killing me today. Yeah, it needed to be in there months ago, but until it hurts, some patients won't come in.
So what would you do for them? Just like
overnight?
Like 12 at night?
Just give them some medication. If they're a patient of record, if they're not a patient of records, then we'll just tell them to come in the morning, take some Advil or Tylenol, and we'll see you at 8 o'clock in the morning. If they're a patient of record and I know them, I'll probably phone in some narcotic antibiotics and antibiotics. Some people get them to sleep, but if I don't know, they would just come in. So again, spontaneous, that's usually key. And as you hear us talking to patients that come in on emergency, these are some of the things how, tell me a little bit about the pain. Does it wake you up at night? Is it spontaneous? I mean, just watching TV, the tooth just begins to hurt for no reason at all. That's not normal. Spontaneous pain is usually a giveaway that something bad is going on with the tooth. Severe, you know, on a scale from 1 to 10, 8, 9, 10, though that's severe pain. That's not normal. Okay, a little bit of sensitivity, sometimes. Okay, lingering. Okay, if a patient bites down on something or drinks something hot or cold, the tooth hurts and it lingers, meaning it lasts for half an hour, 2 hours, and it's still, the tooth is still aching. That's not normal. Sometimes after we do fillings or crowns, they can have sensitivity or a little bit of discomfort, but it should be, as soon as they take something hot or cold, it should go away within seconds. And that's a normal, we call it reversible at this point, reversible pulpitis or inflammation of the nerve. Irreversible, if it's lingering, severe, spontaneous, constant, waking you up at night, those are not reversible. Those are getting more towards the irreversible inflammation or pulpitis, and that's when we go towards the root canal. Okay, so spontaneous pain, severe pain, lingering pain, tooth palpation. When I put my finger on the tooth, you know, put a little bit of pressure, just kind of palpate around the tooth, on the side, on the buccal, lingual, on the gum. It's tender. That's not a good thing usually. Again, pressure from the inflammation underneath is what's causing the pain. So if you've got swelling wherever, if you've got swelling and I touch it, it hurts, right? Same thing with a tooth. If you've got swelling underneath and you touch it, it's going to hurt. Pain to percussion. So if I tap on it with my mirror handle, and that's a test that we do. We tap on it, tap on the next one. And sometimes, you know, I've got pain over here. I don't know which tooth it is. So I start on the canine. This is tooth number 1. Not bother, you know. Number 2. Just work my way back. You get tooth number 30. As soon as you touch it, they go, ow. That's it. Okay. Again, inflammation, pressure. You tap on it, and it'll give it away right away. So to percussion, or they'll say, every time I bite, my bite just seems off. I bite, and that tooth hurts. Well, why would it be pressure to mastication or pain to mastication? Again, you've got pressure underneath, and usually that tooth will feel high or the bite will be off because the pressure has literally lifted that tooth up. Okay, so you bite down, and that tooth is usually hitting first. Okay, or a little higher, a little heavier than what it normally would be if the inflammation wasn't there. Absence of pain with swelling. So sometimes you'll just get a patient that is swollen. Okay, by that time the infection has found a way of, or a path, we call it a path of least resistance. It'll find a little tunnel, and the pressure will just finally vent out the side of the bone, and then the pus will just go, and you swell up like a balloon. And usually it may not hurt then because the pressure kind of, you know, got out. It's kind of like having a Coke bottle, shaking it up, plugging it up, and that's just ready to burst. And you touch it and it's going to hurt. But you let some of the air out and the pressure out, and it's not going to be as tender. So same thing, some of this swelling, once it swells up outside, some of the teeth won't hurt because, you know, it can vent. Radiolucent presentation on the X-ray, okay, at the apex. So what do we see? If you chart, when we say it's got an abscess or a radiolucency, put a little dot, right? And you've seen the X-rays that you'll see that shadow up on the X-ray. So a radiolucency on the apices of a tooth on the radiograph is it's not a symptom, it's a diagnostic tool, but that's an indication. Okay, so know these: pain, pain, pain. All these are pain up on top. Spontaneous, severe, lingering, pain to palpation, percussion, and then swelling. right? So you guys got to know those. And again, when you're here, when you're shadowing and we have emergencies, listen to the questions that we ask and what the patient responds. And this is usually what the responses are and what we're writing down in our chart. You know, patient, when you write down your notes, usually we put CC, which is chief complaint, and that's literally word for word, you write down what the patient told you. Okay, so we put seen as an emergency, chief complaint. I was up all night with this constant pain that's been hurting me for 2 days. And that's what you're going to write down, chief complaint. Up all night, quotations. Up all night, constant pain for 2 days. Exactly what the words, what the patient says. Usually it's this. All right, so our clinical exam. How do we, once the patient comes in and they tell us what they've told us, how do we find out which tooth it is? Okay, well, we just talked about it. I palpate around, just like the doctor, you know, feels your spleen, feels your stomach, feels the back, you know. They're palpating to see if you go, that hurts, doc. So we're doing the same thing, only inside the mouth. So palpate. Thermal sensitivity. We've got a liquid called Endoice, which is liquid nitrogen. We put it on a cotton pellet, get it really, really cold, and just start going tooth by tooth. And a normal response to cold is what? Or to hot? What's a normal response to hot or cold?
Depends on how hot it is.
Well, per tooth, on the tooth.
Like
Yeah.
Yeah, but when if I put something cold or hot, and I tell the patient, I'm going to put this cold pellet on your tooth, as soon as you feel it, raise your hand. As it goes away, drop it. Okay, so I go tooth number 1, you feel it, and I'll just drop it. You know, within seconds. As soon as you take it off, the hand goes down. Put it on the next one, hand goes up, hand goes down. You put it on tooth number 30. There. And it stays. Okay, so that's not a normal response. Usually it's and it goes down. So within seconds of a thermal, either hot or cold sensitivity, it should go down. Any lingering is not a normal response. And the longer they hold it up, the worse condition it is. Okay. Sometimes it's, you know, they'll hold it up a little bit longer, but not too long. Transillumination we'll talk about. That's when we shine light through it, usually through a front tooth, or if we're trying to find fractures, we'll shine either our curing light through it, and you can definitely see if a tooth is cracked. But when we shine light through the front tooth, it's basically like an x-ray. Okay, so these are some of the tests that we do. Palpate, thermal sensitivity, transilluminate through the tooth to compare it to the next tooth. Okay, so this is, again, think of that as black and gray. Black and gray, that's kind of what the x-ray looks like, right? You've got, you know, you won't see the gums, but you'll see bone here, and then you'll see dentin, and then you'll see enamel, and you can see, you know, the outside. So if you were to see a cavity here, or a deep cavity here, it's you don't even need an x-ray on some of those front teeth. Or on the back, you put your curing light, and you can definitely see the patient says, oh man, I bite down and that tooth hurts. Well, sometimes you can't see these, but you turn lights off and you put your curing light, you can see how the light goes through the enamel, and if this wasn't broken, the whole tooth would light up all the way around. Just like, you know, fiber optics. I mean, it just goes, all the light just travels. But you can see here, the tooth is cracked and the light just stops traveling through the enamel. Okay, so sometimes we use that to find if a tooth is fractured. The other thing is selective anesthesia. Sometimes we can't find, you know, we tap, we don't know. Tap, we don't know. Well, sometimes the patient says it's just in that area, and we'll selective, meaning we pick a spot. So if we don't know, we'll numb up a tooth in the back. You know, kind of to narrow it down. So if it numbs up, then we know that it's, you know, that tooth in the back. If we numb up in the back and then we start tapping or blowing find out what will work so that you can isolate it. And sometimes I can't. I mean, I try everything and I can't, then what do? Yeah. You know what? I'm not sure what's going on, Mrs. Smith. I'm going to have to refer you out. Send them out, give them some pain medication or something, and send them out to the endodontics if I can't find out what it is. But usually we can. If a tooth is really loose, again, the tooth mobility gives it away sometimes because, again, pressure is going to lift the tooth out of the socket, meaning it's going to be more mobile. Or if it's really infected, it's really going to be mobile. Sometimes you put your probe there and you get pus coming out the sides of the tooth there. Okay, so it'll cause, the infection will cause some mobility. There's normally a little bit of mobility on all the teeth, and they're just kind of, again, suspended in the ligament, and when you tap on them, you'll see them move a little bit. But if you're tapping on them and then one, you know, tap on the one next to it, and tap on the next one, and then that one just moves more than the other teeth adjacent, then that'll give it off. And then we've got this guy, which is an electric pulse tester, and it's called an EPT. We put it on the tooth, and it's just a little battery current. We dry the teeth, we put that pulse tester on it, and it goes from 0 to 80. Normal response on a tooth should be somewhere in the low 20s, 20 maybe to 30. And if any of you want to try it, we can try it. We put it on the tooth, and it slowly starts increasing the current. Eventually you feel a little tingling, kind of like what your leg is asleep a little bit, and then it gives you a little zap. You go out, and you pull it out. You take it off. It doesn't hurt, but it does give you a little zing on your tooth. Volunteer?
No, thank you. Like, no.
You want to feel what the patient experience. Get the true patient experience. It doesn't hurt. I mean, you just feel it. You kind of feel. I don't know if it's the tooth kind of getting warm, and then you feel a little something, and it just goes. Kind of like when you put a little 9-volt battery on your tongue.
Oh, yeah.
It's kind of what it's doing to the pulse.
I never did that.
You've never done that? Try.
I'm trying to
Just prayed it. Don't tell her to pray yet.
Yeah. Okay, so again, there are some questions on what we do to kind of play detective on and see which tooth it is. In endodontics, usually it's recommended to use a rubber dam. Okay, and why do we use a rubber dam? One, because it increases visibility. It retracts the gum tissue. But the biggest reason is that it decreases moisture contamination. I normally stick to root canals in the front, and I do very little molars anymore. I refer those out. So I usually can keep it well isolated with cotton rolls. But anytime I do a molar, the tongue will always get in the way, and you got saliva going down inside a canal that you're trying to sterilize. I mean, it's kind of working against you. So we use, if it's a molar, I send them out. So usually if I can keep it dry with cotton rolls, I don't use the rubber dam, but if I can't, then the rubber dam goes on. But again, it improves visibility, it minimizes contamination. We use some irrigation solution, which is basically bleach. So you need a good assistant if you don't have your rubber dam on right there to catch that bleach when you're rinsing out. Okay, because if not, the patient doesn't like it. Okay. So it prevents patients from tasting it. Also, we're using small files or small instruments. If you got wet fingers, you could get a patient to swallow one of those files. So that's another reason why, especially when you're working way in the back on a molar, you want to have a rubber dam. So those visibility minimizes contamination. It prevents the patient from swallowing the bleach, and prevents inhalation or swallowing of files or small instruments. This is kind of what it looks like. You guys will be putting one of these on today. So it's we'll go over what it These are the clamps that go on the tooth or teeth. There's different sizes, you know, for premolars and molars. There's winged and unwinged. These are for the front teeth. If you've got a real short front tooth, put that on. Scissors. This is a hole puncher. This is the clamp holder that you open this up. These are for the baby teeth. This is for the adult teeth. So you just basically punch a hole for the tooth that you're working on, or teeth. Put your clamp on, and then you punch it through, and it looks something like that when it's put on. And I just got, that meeting that we went to Vegas, I just purchased a system. It's called Dry Shield. And I don't know if anybody has seen Invisalign or IsoDry, or IsoDry. It's sort of this, but not this. It's the next best thing to this, I guess you could say. You hook it up to your high-speed suction. It's got a bite block, and it's like, I can show it to you. I just got it yesterday. I haven't even hooked it up. It's like a mouthpiece that goes in the quadrant right here, retracts the tongue, goes behind the last molar, hooks around to the cheek. It's hooked up to the suction. You turn it on, so it's doing basically this, but also has active suction. So it's, I only bought one kit because I'm going to try it out. They had a 45-day free trial, so I got one. We'll see if it works. It's great because the assistant is going to minimize, you know, one hand, or eliminate one hand use for the assistant if it's good. So we'll try that out. I'll show it to you guys. I haven't even opened. I opened one box. He's got like 4 boxes. This is another rubber dam. Here you put a frame, metal frame. This one already has like a plastic frame on it. So there's different rubber dams that are used. Okay, so what are the types of endodontic treatment? Okay, not just the root canal. Sometimes we do some things that try to avoid a root canal. But again, vital means alive, pulp capping. Okay, so this is something that we do if we almost go into the nerve, but we want to see, especially on a young patient, try to see if the tooth stays alive. So methods used to stimulate dentin formation. Okay, there's an indirect pulp cap, meaning that we were cleaning the decay and we almost went into the nerve. Here's the tooth. Here is the nerve inside. And we're cleaning decay, and we got like really, really close. Okay? Didn't really see bleeding, but we were really close. Microscopically, there could be a connection there. Okay, even though I didn't see it, there could be a little connection. So we do what's called an indirect, meaning we didn't directly go into it. So when there is a chance of nerve exposure, a small amount of carious tissue is left. Calcium hydroxide is placed on the top of the area closest to the nerve, and then permanent restoration or temporary restoration is placed. Okay, so we didn't quite go in. We're going to see how the tooth responds. We put, again, in the deepest part, calcium hydroxide, which stimulates reparative dentin. Okay, hopefully we'll get a scar there. Then we can come back, and if we put a temporary filling, put a final filling if it doesn't bother the patient. But again, informed consent, we have to advise the patient what we're doing, why we're doing it, and it still may need a root canal if it doesn't work. Okay, so indirect, we did not directly go in. Direct pulp cap is when we're cleaning and cleaning and we get a little exposure. Okay, so we clean and clean and clean, and we get just like a little pinpoint right here. You get a little bleeding right there. But everything else is clean. Okay, so everything's cleaned out, but we just see a little blood, then again, we'll try it. We'll put a little calcium hydroxide in a base. Advise the patient, you know, I was cleaning, we went into the nerve, but it's a real, like a pinpoint exposure. We're going to try this. I'm going to put some medicine, a base, and we're going to see. Sometimes the nerve, you know, does okay with it, but there's a possibility that the nerve goes bad. You turn off the air, dude?
Compressor? Yes, Patterson is here.
Oh, they're here. That's why it's on.
Well, you know what? I'll knock the air down here.
Yeah. So understand the difference. Direct, indirect. Okay, direct you expose, even though it's small. Indirect, you sometimes leave a little bit of decay just to allow the tooth to try to heal itself, and then you go back. Okay, so this is what we call pulpal bleaching, or not bleaching, pulpal blushing. Okay, just like you blush, you turn red. We clean the decay, and we see that. You know, and I didn't see the bleeding, but microscopically, if I were to push right here, I can punch right through. Okay, so you tell the patient, and I'll take a picture of that, and I'll show the patient this picture and say, see that, Mrs. Smith? We were really, really close. That cavity was really close. We didn't go in, but we're going to try this. It may still need a root canal. We'll see. So you put your base, either Di-Cal, or we use, if we're putting a composite, we'll use limelight. You put calcium hydroxide or limelight, and then either put a temporary or a permanent filling there, and monitor the tooth and see how it does. So pulp capping. If I were to have seen a little bit of blood, then it's direct. If there's no blood, it's called indirect. Okay, pulpotomy. Okay, what was a pulpotomy? You take away the pulp from the where? From the tooth. The coronal pulp. So only what's in the chamber. Okay? So you're going to take the pulp. Here's the... You're going to take the pulp up here in the chamber. Okay? You're going to take this off. You're going to leave this here. Then you're going to put IRM or COE, zinc oxide eugenol, up on the chamber in the crown of the tooth. That's a pulpotomy. Oops, where'd it go? Removal of the coronal pulp, leaving the pulp within the canals of the tooth. Okay, deciduous tooth, pulp within the chamber is removed. Hemostatic agents, meaning we put either form of creosol or hemostat, not hemostat, placed in the pulp stumps for several minutes to stop the bleeding. Okay, so we put cotton pellets there with Hemodet right in there. Okay, so that's on a baby tooth. You can do it on an adult tooth. Okay, and sometimes, especially on a young patient that already has the adult tooth, that we get this, but the root down here is still open. Okay, so if this root hasn't finished forming, if the root is still like this, okay, this is the nerve here still. The nerve and blood supply are coming in through here. But you really haven't closed the apex, so you can't do a root canal there. Because you can't seal the end of the root. It'll fail. So what's done, you do a pulpotomy, you put medicine here, and you hope that you close this root. Okay, it's either with a bridge there or somehow it closes, and then the specialist can go in there to finish a root canal later. Okay, so this procedure is done on a permanent tooth that is not yet fully developed. Pulp in the chamber is removed and pulp within the canals is left. Okay, so you're just doing a pulpotomy. Oops, sorry guys. goal is to get secondary dentin formation or to completely close the apex of the tooth. Okay, so again, you go in here, remove what's up in the coronal part or the chamber of the tooth, you leave what's in there. Okay, again, I think we've seen this before. Same picture, again, you've taken away what's in the chamber, you leave, you can still see the blood supply down there, so it's still vital. There's still blood supply in there, and usually these teeth, they stay. Every now and then you'll get one to fail, but usually these will stay. You put a stainless steel crown or a composite, and they'll stay till the patient loses it naturally. Okay, again, and then these are the x-rays, that's how they look. But this is vital down here, you've got live nerve tissue. Apexogenesis, okay, this is trying, again, when we're trying to close the apex of the root. If the tooth is still not fully formed, the process of performing a pulpotomy on an adult tooth with the goal of apex formation, okay, so that's what this treatment is called. When you do a pulpotomy on an adult tooth that does not have apex closure, you put that medication in there to get apexogenesis, to allow that root to finish forming. Okay, now pulpectomy, that's not just taking the chamber part of the nerve out, you take the chamber and what's inside the roots. And we talked about this with the pediatric, in the pediatric lecture, okay, it's the same thing. So, in baby teeth, you do that. We put zinc oxide eugenol or IRM in the chamber. If it's a pulpectomy, we put zinc oxide eugenol inside the canal because it resorbs. In adult teeth, we use files to go in there and really clean out the files. Okay, and that's called debridement. To debride means to remove whatever tissue or tartar from a tooth. Okay, if a root canal fails, we send them to a specialist, and this is what they do. They try to save onto it if the patient wants, and they do a procedure called apicoectomy. Okay, again, ectomy meaning they cut the apex off. A procedure that involves the removal of the apical portion of a tooth and surrounding tissues. I think all of these are matching. You guys got to know the definition and match. Okay, to do that, the surgery involves opening up the side of the gum at the end of the root, and they curettage, or they go in there with a spoon and clean out the infected tissue, cut the end of the root off, and then they do a retrograde filling, or meaning they put a filling from the bottom of the tooth, which is a restoration placed at the apex of the tooth following apicoectomy. Okay, so if this tooth had an abscess and it was failing, say it had a post here, the endodontist goes in, opens the gum, curettes the tissue, cuts off the end of the root, and puts a filling down here, a plug. Okay? So he goes in there and does a root canal, or not a root canal, but plugs the root canal from the bottom, because for whatever reason it's failing and it's leaking, and so he goes in there to try to seal it. So that's the retrograde restoration. This is retrograde restoration, meaning there's a restoration placed at the apex following the cutting of the end of the root. Okay, so here you have a failing root canal. He has a metal core buildup, okay, which was going to be really tough to drill through. So the endodontist decides to do an apicoectomy, and you can see here how they cut the end of the roots off, and here you can see the different shade of the retrograde filling. It's some sort of a more dense filling than the gutta percha, and in there on both roots. And usually these heal. You'll see them, you'll just grow bone right here, and they do fine. But again, anytime you're doing these types of procedures, the patient always needs to know that this may fail too. Okay? So again, it's the patient deciding, yeah, let's try it. We'll see what happens. Or no, let's just take it out. Let's place an implant. Okay, so instruments and materials, we have hand pieces. We're using really fine files to go inside the canal, and we have to regulate the speed. You can't just go with the rheostat and go fast and slow, because you'll break those files. So we have special hand pieces for doing root canals. They're rotary, okay, so they spin. They're electric, and they're instruments which spin specially designed files to remove pulpal tissue and shape and enlarge the root canals. Before we used to go by hand, go in, twist, pull, go in, twist, pull, go in, twist, pull, until you're slowly widening the canal. Now we put them on the handpiece and you go in and out. Okay, so this is one of the ones that we have. And again, you put the file here, and you select what speed you want it, and what, depending on the size file you have, and you just slowly go in, and it regulates the speed. It's a constant speed, no stop and start, because that's what breaks the files. The broach, I think you've seen it before. It looks something like this. Okay, you put it in the tooth, and those little sharp barbs will pull the nerve out. I don't know if you had seen it before. Have I showed you this picture before?
Yeah, you showed in the bottom picture. I don't think it's in the top one.
Yeah, so this is actually the broach. Okay, so it's a little file with little hooks on it. You go inside, and just pull that nerve out. So that's what the broach does. Reamers, they're used to clean and enlarge the pulp canal. Reamers and files are pretty similar. They're just twisted differently. They have the cutting ends differently. Endodontic files are available in multiple sizes. They're used to remove pulpal tissue and enlarge and shape the root canal. So into this canal, we're going to put the files, again, to remove tissue and shape it so that we can actually fill it. If you see a three-dimensional picture of the inside of a tooth, it's not straight. It may look straight on the X-ray, but it's got little hooks and deviations that you really can't see. So and if you try to put just a straight filling down, you probably won't be able to unless you shape it. And basically what we're trying to do is taper from a small end, because we want it plugged, from the bottom, and we just kind of slowly taper it to the top so we can fill. Measuring stops are a little metal or a little rubber ring that we put on top of the file to measure how long the tooth is, because the length of the tooth is critical when you're doing root canal. Not all the teeth are the same length. Okay, so we have to measure if it's from here to here, it's 22 millimeters. Every file we put in the tooth has to be 22 millimeters, because we want to fill right to about 1 millimeter to half a millimeter from the end of the root. And if you're putting in a file at 20 and then one at 22 and one at 25, you'll never get a good root canal. You always, once you establish it, then you always set your files to that. Okay, and these are the little stops. These are the files, and we'll talk about them a little bit. These are the rubber stops. You just slide it up and down on the file depending on the measurement. They're usually color-coded. Everything in the root canal, if you're talking about a 20 file, it's telling you that it's the width. Okay, this 20 means that the taper is a 20 file. So all 20 files are going to have the same width. The 25 is going to be a little bit thicker, 30 a little bit thicker, 35 a little bit thicker. So this number on the file is the width of the file, and you'll get different numbers. We may tell you that we need a number 20, a number 21, 20 file. So 21 meaning the length from here to here is 21. Then we have 25 millimeters, and we have 30 millimeters in length. Okay, so we may need a 25, 20 file, meaning it's a 25 in length, but a 20 in diameter. So the first number will usually be the length of the file, or I need a number 30 file, 20. A number 30, 20 file. A number 25, 20 file. A number 21, 20 file, meaning we've got a 20, I'll show you right now. I see some blank stares. Okay, so we've got a 21, we've got a 25, and we've got a 30, okay? So this is a 20, this can be a 20, and this can be a 20. Okay, so I need a 21, meaning 21 in length, 20 file. I can have a 25 in length, 20 file, or a 30 in length, 20 file. Okay, and that just depends on how long the tooth is. If I have a tooth that's 25 millimeters long, then I can't use a 21 file, right? Because it's not going to go all the way to the end. I'm either going to have to use a 25 or a 30 and adjust the stopper. Correct? You guys will see those right now. Okay, so there's a stopper. The rotary files, they just have the stop right here, or the latch. You put it on a slow speed or the electric handpiece, and you latch on. But it's the same thing. You'll have a 20, depending on either a 21, a 25, or a 30 in length, and then depending on the width you can do. The apex locator, this is kind of like what we have, but only a little newer. It basically measures the end, how long the tooth is. So we put a 30 millimeter file because we want a long one, make sure that we go to the end. We put a file, and then we slowly start going inside the tooth, and it's going to start telling us where, start beeping. Beep, 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 and right when you're getting to the end, it'll go beep, and you want to be right here, right on the green, or just slightly on the yellow. You want to be about 1 millimeter to 1/2 millimeter from the end. If it goes beep, then you're probably all the way too far out. Okay, so you take the file out, measure it, and that's how we determine the length.
So I got some samples of the files if you want. Just pass it around.
Once the
All the same diameter. But you can see the difference. 21, 25, 30.
once you figure out what length it is, then either you or the doctor will have these. This is a thumb ruler or a finger ruler, or there's these little neat devices which you can't see from back there, but this says 12, 13, 14, 15, all the way to 20. Okay, so all you do is you put your stopper and you push your file down, and it'll set your stopper at, you know, what this is at, like 12, 15, 14, 15 millimeters. So you can see how it's tapered down. So the further down you go, the longer your stopper is set. You can either do that or put it on your finger ruler and then you measure it. You just slide it on, and you guys will get to do that. This is a file holder, little sponge, and it's got a ruler right here. So you put the file and measure how it goes, how far it goes. Okay, absorbent points. They're like paper points, like Bounty, quicker picker-upper. Okay, because we're using that irrigant or water or something to rinse the inside of the canal. And before we fill, we have to make sure that it's completely dry, that it's not bleeding and it's completely dry. So we use these files, or these paper points, and go inside the canal, and it just dries it up, just sucks up all the moisture. Again, you can see there that they're color coded. 45 is, if you have a number 45 file, the head is white. If you have a number 50 file, it's yellow, and everything is the same color. Everything's color coordinated. These little measurements here are in millimeters. This is 18, 19, 20, 21, 22. Okay, and again, those measurements are standard. Again, irrigant, or what we use to irrigate the inside of the tooth, we use bleach, household bleach. Okay, so once we start debriding in there, we put it in a little endo syringe. We get your suction right on the tooth there. You need, again, if you're not using a rubber dam, you need that suction, a surgical suction right on top of the tooth. And you irrigate and you suck that bleach out. I use bleach straight up. Dr. Cervantes dilutes it 50-50. Okay, so it just depends on what you want. Okay, gutta percha is a material that we use to fill the canal. Okay, gutta percha is what we use to fill the canal. It's just a material that the body accepts. It's a rubber material. We use a heated gutta percha, or you can use these points that you just go in there and plug with cement. So it's gutta percha. And the cement that we use, just like we use cement to cement crowns, we use cement to cement the inside of the gutta percha, inside the canal. Okay, so it's usually 1-to-1. You mix it just like, kind of like Dical, like the calcium hydroxide. Same, looks kind of the same. Mix it 1-to-1, and you don't need a lot. And you either pick some up with a file, go down in there, and you seal the inside of the tooth. The word to fill, the dental terminology means to obturate. So the word obturate means to fill. Fill the canal. We're going to obturate the canals with gutta percha. So those are all number 10 files, but they're different lengths. So you've got a 21 or 8s. So you've got a 21, a 25, and a 30 number 10 file. Length is just different. Okay, so what's the steps? I'll go real fast here because then we'll go into the lab. So you anesthetize and you place the rubber dam. Okay, so there's a tooth that's going to need a root canal. The rubber dam is placed. The first thing that we do, we access using a high-speed burr. We find the chamber. And we start to remove. This is kind of what we would see. Once you access in there, you'll see blood inside the canal. You find the 3 canals or 4 canals or 1 canal, whatever it is. Then you start to remove it with the broach and then your rotary files. Just start going in there. After it's removed, we use the apex locator, again, to establish our length. Once we establish our length, we can take an x-ray. Oh, my battery's running low. So if you want, you verify the length with an x-ray. So there's a file in there. Use your apex locator. And again, this is what we're looking for. You want the file down inside the tooth, that's long. You want it right before you get to the end of the root. And your apex locator, if you see this one right here, that's an x-ray of that file right there. And I don't know if you can see from way back there, but it's out the end of the root a little bit. And you can see here at the end of the root how the file's sticking out. And you may only see usually, and why we normally go 1 millimeter from the end of the root is because the apex of the tooth is usually not right at the tip. It's usually about 1 millimeter short off to the side a little bit. So that's usually why we will stop about 1 millimeter short of the end. As you can see where the file comes out right here. And here it looks like you're right on or right at the edge, but you're actually, you're about a whole millimeter too long. Then we rinse it with sodium hypochlorite, is another name for bleach. Okay, if you're assisting or shadowing and somebody tells you, can you go get me sodium hypochlorite? What is it? Bleach. Okay. And again, you can see here, you put it with a little syringe right down into the canal in a surgical suction, just picking it up. Then you use the paper points to dry it. Once you dry it, depending with whatever size of canal it is, then you measure your gutta percha to, if it was 12, 15, 18, whatever the gutta percha is. You mix the sealer, and then you put the gutta percha in there. You take a final, you burn off the gutta percha at the end, and you put the temporary filling. Here's a hot instrument to burn off with the excess gutta percha. And again, this would be our before. This would be measure a picture, an x-ray of our files, making sure they're good.
The trial rate.
Yeah, trialing, and then we try in our master cones, make sure before we put the sealer, and then our final. So usually there'll be 4 x-rays. You would have to take a before, trial working, master cone, and a final x-ray. Yay. Alright, take like a 5-minute jumping jack break. Go run a mile.
Yeah.
We'll do the lab real quick for the root canals.
And I'm already hungry too. We're halfway there. Starving. Did you ever take that last test?
Oh, you did want to take it?
Last week? Yeah, see if you can give us our test back, because I want to read the part of mine. Can you give it back to you yet? He gave me mine's back already.
Oh, you did? Okay.
I don't think it was. That's weird.
Because he was waiting on for someone to take us.
We didn't take it. It's like,
Okay, so she missed it or something. So I'm gonna ask him for that.
how'd you know? I got an 80.
But wasn't there 2 parts, like the lab part and?
I didn't look into it.
Oh, okay.
I'm scared too. That's, I think that's the test he gave you back. Martin's?
Good morning.
Oh my god. Oh, look at that. How
Holy, that's a
cool.
big bird. I know, I just ran.
He's like, hello.
Like, what are you guys doing?
I guess that's okay. Can we see anything? Look at him just like bobbing his head.
Just chilling. We've never seen him before. He's like, hey, is it in there?
Big too.
I know, he's a giant. He's just random ball of crap. I know.
Look at how tall his
Burgers,
legs are.
I think he'll take your eye out too. I know, right?
Oh, look at that.
I know, we got pictures.
Man, my son would love that thing.
My cats would like love that thing.
You
Your
can't see
cat.
it.
My cats would love
Watch that down. Did you watch this?
Huh?
Did you see this guy?
What
It's
the?
so hot.
Can we talk right here?
Oh, I have a crappy cat. Oh my god.
He wants to fight the hawk in front of him.
He's just watching you guys.
No, that's it.
No, he's
It's like-
putting himself in the mirror.
That's it. Watch, he's gonna attack the.
Oh my goodness.
The glass.
I know, he's just looking at me.
He's like,
I'm busted.
It's like, throw a mouse or something. He's getting leg day though.
It's like posing for a selfie. Look at him. He's like, now this angle.
It's a big hawk.
That's huge.
That's pretty cool. He really likes
Oh,
looking
wow.
at himself.
Yeah.
Enjoying the
Look
video.
Watch him fly right now, right into the window like,
We'll jump back.
see who's tougher, you or me? Come on.
I saw it.
Oh, thinking every time I flex, you flex.
Yeah.
You can read my mind.
Like, I turn, you turn. What's going on?
Look at that. You can read my mind.
What?
What's going on?
Oh, look at.
Everybody else took pictures, take a picture.
Probably gonna be right now. Right when they go on camera.
You're late.
That's why I was like, what now?
Oh,
see?
You scared him.
And you always
He's
like,
like,
Like, I've had enough pictures. Send us the bill.
you don't know this, but I'm actually a famous hawk.
Exactly.
We're on like top of
All right, so we'll go over pretty much, it's kind of the same thing. We'll just go into some materials and show some samples of materials and go over a root canal procedure real quick here. Forgot to turn this guy off over here.
Look what those
We had